All right, just while these guys get off the desk, I'd like to introduce our next speaker. Dr. Kettle's responsible for some of the highest birth rates worldwide in third-party fertility treatment. Dr. Kettle possesses an extensive CV and double board certification. His clinic is the only program offering a success guarantee refund plan for elective single embryo transfers. Dr. Kettle and his team have assisted many Australian families, so welcome to the statement. I'll just give you a couple minutes wind up when getting towards the end.
Okay, sure. Thanks for having me today. We're going to kind of shift some gears today because everything that's been said so far has been really predicated on success, which is wonderful. And most of the people that have spoken from this podium have had success in surrogacy and have babies to show for that. But it's a journey, and we've heard some very interesting stories about that journey and how difficult that journey and that process can be. And I've been asked to discuss embryo transfer decisions because most of these surrogate babies have come through the process of IVF, and during the process of IVF, a group of embryos are created, and then some decisions need to be made about how to transfer those embryos. And do you transfer one embryo? Do you transfer two embryos? And how does that decision-making process take place? And I've titled my presentation, One Perfect Healthy Baby. And then down below is a paradigm shift in IVF. And I'm going to work through with you over the next few minutes how I think our field is going and how it really is quite different in 2015 than it was even just a few years ago. Now, when I was looking over my slides and I saw all these graphs, and I knew that most of the people in the audience probably hated high school science, I said to myself, I should probably add in a little bit something different than just slides with bars on them. So I've added some cartoons to these presentations, and I hope you'll either forgive me for the graphs or you'll forgive me for the cartoons. But here's the first one. And I'm not going to read the bottom. That's going to be kind of up to you. But I think that this really does illustrate how, everybody is really after a perfect, healthy baby. And one of the things that we've learned about getting to that perfect, healthy baby is that multiple gestation can be a problem in that journey. And this is a slide that illustrates maternal morbidity, or pregnancy complications that happen in the mother as it compares to carrying a singleton pregnancy versus carrying a twin pregnancy. And in this particular group of complications, I've just listed a few. And the purple bars are singleton pregnancies, and then the blue bars are twin pregnancies. And you can see that in pretty much every one of those three, the complication rate in twin pregnancies is higher. But it's also true for the baby. So the baby's morbidity in pregnancies, in twin pregnancies, is higher than in singleton pregnancies. And again, this is just 4, but you could pick pretty much any fetal morbidity that you would like to, and when you compare the morbidity in twins, it's higher than it is in singletons. Now, in this particular slide, you can see that the y-axis goes from 0 to 40, and I did that to illustrate the differences in the size of those bars. And if you were just to change that and now make the y-axis from 0 to 100%, and now you look at those differences in the bars, they don't look as impressive. So if you were just to take the 50% mark and say, okay, I could come to the conclusion that most twin pregnancies do fine. So yes, you can say that there's more morbidity, but still, most twin pregnancies do fine. And people have that perception. And the public certainly, in a lot of instances, has that perception that twin pregnancies do fine. In fact, this is a study that looked at parental preferences at the very initial fertility consultation for a group of people living in Denmark. And you can see by that pie graph that 62% of interviewed couples, and before they had completed their first fertility treatment, preferred twins. and 37.9 preferred singletons. And why is that? And I'll say that I'm going to start that by saying that in Denmark, 3 IVF cycles are publicly funded. So the economic driving force in decision making, at least in the Danish community, isn't necessarily all driven by dollars. But still, 62% had as their primary outcome a twin pregnancy. And I've listed several reasons for that. One was a desire for siblings. So they wanted to have more than just a single child in their home. The other was this generally positive attitude towards twins. Again, most twin pregnancies do fine. Third, minimize the stress of multiple treatments. And we've had some people share some wonderful stories about going through what would seem to be an outrageous number of treatment cycles and still end up making very difficult decisions for themselves. So going through multiple treatment cycles is clearly on people's minds as they're making decisions about how they're going to get to the family that they want. And again, just indicating once again that in this particular group, economic considerations were not that important. So we are getting better, but we're still not perfect in reducing the risk for twins. So this is just a look at sort of how things have evolved in the world of IVF over the last almost 20 years. And I've used what I call the SART National Database. That's in America, that's the Society of Assisted Reproductive Technologies database, and that's published every year and is actually used worldwide in a lot of different countries to kind of gauge success rates. And in the United States, each clinic has to report their own individual data, and then it's coalesced into a national data statistic, and that's what this is from. And I chose the less than 35-year-old model because those are typically young women and usually have pretty good success rates. And I think the comparison is easier with that group. So these are reporting years 2013, which is the most recent released data set, compared to 10 years before that in 2003. And then 1997 was the oldest I could find. So that's why that is out there. And if you just take a step back and you kind of look at that, those bars there, the purple bars represent the percentage of births that were singleton births. The blue bars represent the percentage of births that were twin births. And the black bars represent the percentage of births that were high order multiples, meaning triplets or greater. And you can see that the purple bars generally inching upward, higher percentage of singleton births, and clearly the black bars, the higher order multiples are decreasing. And if you expand that a little bit more, this is a closer look at that same data. I've just expanded that y-axis again. And you can see that now I've eliminated the singletons, but you can see that twin births are still about the same. So what we really reduced are high order multiples. So we've been quite effective in that. And in fact, even the conversation today, if you listen about it, is more about twins, and it's not really come up much about triplets or quadruplets or other higher order multiples, because we've done a pretty good job of lowering the risk for that particular pregnancy complication. And how have we done that? And it's pretty easy. It's not so hard to figure out. You just transfer fewer embryos. So this is, again, same data set from those 3 different reporting years. And you can see back in 1997, which is sort of my vintage, we used to transfer 3.7 on the average, which means there's a lot of transfers that were 4 or 5 embryos. That decreased to 2.6 by 2003, and as an average, 1.8 in the most recently released data set. So we're getting better at reducing the number of embryos that we transfer. Okay, that's fine and good, but what about elective single embryo transfer? Now this is a new reporting group, and what it means is that the physician and the patient, and could be the surrogate, are making decisions about single embryo transfer, but there's more than one embryo available. So they could have put in 2 if they wanted to. So we're calling this elective single embryo transfer because that's a decided choice. So the decided choice was to only put in one embryo when you could have put in two. And here's the success rates. Again, if you look at that same 3 data sets. In 1997, this wasn't even reported. Nobody would have dreamed of doing that. By 2003, not even 1% of IVF cycles were conducted with an elective single embryo transfer. By 2013, it's up over 20%. Significant improvement in those numbers. I would call that a pretty good improvement in the way that IVF is being practiced. Now, why not, it's called ESET, why not elective single embryo transfer? Because there's been some pressures that have come to bear on that decision making. First of all, it's been pretty clear, maybe up till now, but pretty clear through the last many years that single embryo transfer success rates are lower than with double embryo transfer success rates. It's probably the most important driving force in the decision making of how many embryos to put back. So success rates have been perceived to be lower when you put in just one. Also, we've talked about this already, many, if not most, couples actually desire twins. So having a twin outcome isn't perceived by them to be a negative outcome. And in the context of IVF success rates, putting in a single embryo transfer actually penalizes the IVF center because of the lower success rates. So if potential clients, patients, are looking at individual clinics and they see their success rates, if that clinic was a strong proponent of single embryo transfer, it's quite likely that clinic's success rates would reflect the lower pregnancy rate. And that might influence clinic selection. So by the nature of the way that the data was reported, there was a disincentive by the center to transfer single embryos. Now that's going to change, but that data set and that new way of analyzing data has yet to there hasn't been enough time to get that into the press. But the reporting rules for SART are evolving to reflect this. But currently, up to now, for anybody who looks at the most recent SART database, the programs that do a lot of elective single embryo transfers are being penalized in their pregnancy success rates. Also, there are couples that don't want to go through multiple cycles. I touched on this a moment ago. Going through these treatments is not so simple. It's not so easy. There's a lot that's invested. It's not just the physical part or the financial part, but the emotional toil of having negative pregnancy test after negative pregnancy test is difficult to measure, but it's certainly real. And also, there's a payer conflict, at least there is in America. And that's because fertility treatment, I'll speak to California, fertility treatment is most commonly not covered by insurance benefits. So fertility treatments are almost always the burden of the intended parents. And these treatments, as we've talked about already, can be quite expensive. But once the pregnancy is established, now the insurance takes the burden of covering the cost of that pregnancy. And if there's a twin pregnancy, those cost burdens are now shifted over to the insurance company. So you have some conflict there. If it was the insurance company's choice, they would prefer there be single embryo transfers and singleton pregnancies because they don't really care how many treatment cycles it took to get there because that's not on their dime. If you're the patient who wants, obviously, to begin or extend their family, they want to get that success as quickly as they can. So putting in 2 embryos has some intoxicating appeal to them. So because of this payer conflict, there's also sort of a shift away from single embryo transfers. Now, this is just an illustration of what I was talking about when I said that success rates were lower with single embryo transfers versus double embryo transfers. And this is what's called a meta-analysis. Again, a little scientific deviation, but a meta-analysis is a powerful statistical tool because what a meta-analysis does is it's a group of investigators that take multiple clinical trials, so 10, 11, 12, 20 clinical trials, and they dump all of the data into a computer, and then they generate powerful conclusions because of the numbers that are involved in all these multiple trials. And this was one such study published in 2010, looking at the success rates of single embryo transfer, that's in the purple bars, 26%, versus a double embryo transfer, almost double. So clearly a price to pay in the success rate of single embryo versus double embryo transfers. But at what cost? And that's in the bars to the right, where the multiple pregnancy rate in the double embryo transfer, now these are twins, is 29.8% versus in the single embryo transfer essentially 0. So yes, it's true, double embryo transfer has a higher success rate. Yes, it's true, double embryo transfer has a higher multiple rate. And not only that, but there's issues in the other areas of medicine that have put some pressure on the practice of IVF. We're not the only ones looking at these outcomes. And in fact, in the nursery, everything isn't necessarily perfect. And this is a study done and published in the Journal of Pediatrics a few years ago by a group of Canadians who looked at the outcomes in the nursery. And pretty much the conclusion is just illustrated in the title of the paper. And if you just read that, the epidemic of multiple gestation and neonatal intensive care unit use. And here's the zinger, the cost of irresponsibility. And that's the title in the journal. And I never really thought I was an irresponsible person. Certainly my mother doesn't think I'm an irresponsible person, but there's a lot of people that might believe that putting in more than a single embryo is irresponsible. So they said, and they reported that 17% of Canadian neonatal ICU, NICU admissions are from infants that were born from multiple gestations after ART, and ART is IVF. And they propose that a policy of ESET would prevent on the order of 30 to 40 deaths, 34 to 45 severe intracranial bleeds, 13 to 19 retinal surgeries, and a staggering number of hospital days. So we should be able to figure this out. So we've now come to the conclusion that twin pregnancies aren't as good as singleton pregnancies, but at what cost? Success rates largely. So how might we be able to figure this out? And I'm going to touch on pre-implantation genetic screening, but I'm not going to go into it in any detail because Dr. Feynman's going to teach us all about this later on during this conference. But I do need to touch on it to make a valid point. So PGS, or pre-implantation genetic screening, is a technology that's been available for a very long time, actually, since the 1980s. But the technology of the day used a technique, it's called FISH, which stands for fluorescence in situ hybridization. And using that technology, only a limited number of chromosomes could be assessed. In fact, the first published papers using this FISH technology in genetic screening looked at only 3 chromosomes. Now we know that a normal human female is 46XX. That's 23 matched, what are called somatic chromosomes, and then a set of X chromosomes. So there's a whole bunch more than 3 chromosomes. As this technology evolved, the most that could ever be screened for was 11. So still, half the sets of chromosomes. Okay. The biopsies at that point were done on developmental day 3, early in development, and turns out that there wasn't a very significant improvement in pregnancy success. So there must be a better way. And in fact, there has been some significant evolution in the process of PGS. And current technology does things differently. The cell that's biopsied is a different cell. The technology is now available to screen all 23 chromosomes plus sex chromosomes. There's less risk of what's called mosaicism, which is where the chromosomes haven't been sorted out in the embryo. And one of the downsides potentially to this is that you may need to freeze the embryos. Now that has some potential advantages as well. And I just illustrated this blastocyst embryo. There's a little cluster inside that blastocyst. That's called the inner cell mass. That's going to become the baby, and they stay away from that. So now the biopsies are done in that outer rim of cells that are destined to become the placenta. And the embryos tolerate that much better. So what if we could now look at transferring a single embryo, but make sure that embryo was genetically perfect? And now what happens to success rates? If we utilize that higher potential to screen the embryo that's selected for transfer. And that's what this paper published just a short time ago, where they did a randomized trial in women who were less than 43. So that's a pretty broad range of women's age. They transferred a single euploid. Euploid means normal, genetically normal, versus 2 that were untested. And this is what they showed. They showed that now success rates were pretty comparable. So in this case, purple is single embryo, 60% success rates, darn good, compared to 65% with a 2 embryo transfer. Pretty comparable success rates. And the multiple rate is way different. So when you're transferring 2, in this particular study, a 50% multiple rate, but again, essentially none when you do a single embryo transfer. So this study required that all the embryos be frozen. That raises some alarms in some people's minds because freezing the embryos may damage the embryos, but I'm not sure that that's really the case anymore because, again, there have been some evolution in the technology here. So there are recent improvements in the way embryos are frozen, and in fact, there's some papers that suggest transferring frozen embryos have some benefits. It may be safer on the woman who provides the egg, either the intended mother or maybe an egg donor. Reduced implantation in stimulated cycles, some thinking that in stimulated cycles embryos don't attach as well, less morbidity on the mother, and it greatly simplifies third-party scheduling. So if some of you were considering third-party reproduction, if you can get to embryos, screen the embryos, now you know which ones are genetically perfect. Now you bring in the third-party potentially surrogate, and the scheduling is much easier, particularly international scheduling. So paradigm shift in the way that they're freezing. I'm going to skip that. Just going to kind of conclude in, so how do we get to this one perfect healthy baby? Well, I think I've made the point that twin pregnancies are inherently riskier for mothers and babies, and that twin pregnancy can be avoided by transferring a single embryo. So if we can evolve in this paradigm shift I'm talking about to doing pre-implantation genetic screening and then transferring a single genetically perfect embryo, we may end up with that probably most desirable outcome, which is one perfect healthy baby. And I'll conclude there.
Sorry, we've just hit lunchtime now. There's just one question here, so we'll take that, and I promise we won't be more than 3 minutes. Just one quick note. The room's going to be split up into 2 after lunch. So this is room 1, that's room 2, and then you just look at the guide to see which sessions you want to attend.
I just want to preface this by saying that I'm talking about this in the context of surrogacy. I am a mother of twins. We conceived naturally fraternal twins, and towards the end of the pregnancy, I got put into hospital for 44 days. As a surrogate, I would not advocate any more than one embryo being transferred. It would be a burden on the woman, and it's also a burden on the intended parents with the higher incidence of NICU and special care. I would never want a surrogate to feel resentful towards the children that she were carrying if she did need to go into hospital for an extended period of time. Our situation, fortunately, ended on a very good note, 2 happy, healthy babies. I would never carry twins again if I had the choice. I saw my daughter 3 times a week while I was in hospital, which was hard on me. And it was hard on my husband as well, and I would hate for another surrogate to have her family go through that as well. And quite often people say to me, that's fantastic, you have twins, it's 2 for the price of 1. I can tell you it's 2 for the price of 2. It is not easy. Some days it's easier to stay in the house than it is to leave. So please, this is something I feel really strongly about. If you're going down the process of surrogacy, please consider only one embryo transfer into your surrogate for the health of your future child, for the health of your surrogate, for the health of her family. This is a really important thing. And I thank you, Michael, for all the statistics that you've provided, because it's very easy to see them on a page, but when they're put into perspective as they were, and also from talking to people who've had multiples as well, it's not just about, you know, the end product, it's about everything that you go through before that. And one of my other voluntary roles is to support women who've been placed into hospital on long-term bed rest before the birth of their children. And I send them care packs, and we go through everything that could possibly happen. Some of them have families and children that they don't get to see, particularly if they're regional. They get sent to large hospitals and they don't have a lot of support. And we work through all the possible scenarios. So things such as premature birth, caesarean, and the risk associated with that, and also the health of their children post-birth. So as an intended parent, I think it's really important to think about the health of your future children and what the potential consequences are for multiple embryo transfer in that circumstance.
Well said, Renee. Thank you.